Okay. Good evening, everyone. Welcome to today's webinar from Aspira Women's Health. We appreciate your time and attendance for tonight for this webinar presentation. Some housekeeping notes before we get underway. The webinar will be recorded for the benefit of those who are not able to attend. During the presentation, you are welcome to post questions for the panelists, and we will address them during the Q&A window after the presentation. And that's it. On behalf of the entire Aspire community, it is my pleasure to now turn the floor over to Dr. Ryan Phan, who will introduce our topics and presenters.
Thank you, Yana. Good evening, everyone. Good afternoon for the West Coast side. Really exciting to have you joining us for Aspira webinar. The title of the webinar tonight is Ovarian Cancer Risk Assessments Utilizing the Multivariate Index Assay. So this is a really exciting time for the company, and I want to quickly go over the agenda tonight for the webinar. The first one you already hear, and we will go over the overview of the product of Aspira offering regarding ovarian cancer risk assessment. And joining me tonight, really exciting to have three excellent physicians. We'll discuss various topics of ovarian cancer. First one will be Dr. Charles Dunton, who's also our CMO of Aspira. We'll discuss about the cancer care for ovarian cancer patients. And follow up with that is Dr. Tamika Sea. I'm sorry, Dr. Sea. Should have pronounced correctly. We'll discuss about Over1 Plus, one of our well-known products for assessment for the patient who plan for surgery. And more excitingly, that you will hear more from our principal investigator, but also our well-known KOL, Dr. Gerard Reilly, discuss about the upcoming new product from Aspira called Overwash. And we will follow the discussion tonight with a Q&A. Next slide, please. So let me go over quickly about who are we, Aspira Women's Health. So we are the company that focus exclusively on women gynecologic health, particularly ovarian cancer. We have been in the company for in the business for more than 10 years, and we transformed the way for development of gynecology, leading technology for assessment of particularly starting with ovarian cancer. We engage with many world-class academic and medical institutions and working on develop our technology that the first and the world-class risk assessment for patients starting with ovarian cancer. And one of the products that we're well known for the company called Over1 is a part of our Over suite, in which that it's FDA clear product that we help the healthcare provider assess the risk of malignancy for women with adnexal masses. And in this over suite product, you will see in the next few slides, including both Over1 Plus, which have combined both FDA clear product called Over1 and Ovarian. The second product that you hear from tonight will be the Overwash. That's a new upcoming, about to be launched, a product that assesses the cancer risk for women with a pelvic mass, initially determined by indeterminate or benign. And you will hear more from follow-up. So we're really excited to have these two products that supporting the clinician to provide assessment for patients with an adnexal mass from initial determination of how the patient to be provided clinical care to surgical management of patient. Next slide, please. So now I'm going to turn over the slide, the floor for Dr. Dunton, who also Aspira Chief Medical Officer, will give an overview of ovarian cancer care. Dr. Dunton.
Good evening, everyone. Happy to present this brief survey of ovarian cancer. I am a GYN oncologist. I practiced in the Philadelphia area for over 30 years. Trained at the University of Pennsylvania for my fellowship in cancer. Was on staff at Jefferson Medical College for 10 years and then moved out to the suburbs where I had actually done my OBGYN residency at Mainline Health. I've been involved with Aspira for the past 4 years as a consultant and now as a chief medical officer. So if I could get the next slide. So I've been involved in taking care of women with ovarian cancer for many years, and I do think that Aspira has significantly better testing to triage patients to the right doctor or for watchful waiting and expectant management. So history of ovarian cancer risk assessment, basically clinical exam and ultrasound. These are subjective. We have just got a paper accepted for the SGO looking at going over ultrasound results from our database, found out about 66% of the ultrasounds that were done in these studies would be considered indeterminate by two separate investigators. Physical examination certainly is limited and is not successful in helping us assess women for ovarian cancer. The CA-125 has been used for many years, but it is really only approved for monitoring women who have ovarian cancer and is not available for preoperative assessment. Medicare will not cover that for preoperative assessment. Roma is another alternative, but my data that I've reviewed, I think that the OVA1 Plus is better. Especially for younger women and premenopausal and early stage, which are much harder to detect. I think we'll see a slide about paper we published looking at negative CA-125s and how the pickup was for risk assessment for the patients who had a malignancy. And of course, we can't biopsy the ovary preoperatively because if there was cancer there, we could change the stage and possibly need chemotherapy if we ruptured a cyst with an ovarian cancer. So there is a need for improvement. Next. And again, the unfortunate fact that hasn't changed much, we have improved with our treatments for ovarian cancer. Probably 50% of the women, even with advanced stage disease, are still alive at 5 years, but most of those are in third or fourth line treatment many times. So where we can make a difference in getting the patient to the right doctor who can do the staging is in stage 1 and 2, where we see 5-year survival rates between 75 and 90, over 90%. And this is where OVA1 Plus comes in, where it picks up early stage disease. And again, if you're picking it up in younger women, you can make a very large difference in their lifetime by having the right surgery done, not having to go back for a second surgery. Next slide, please. So ACOG guidelines, American College of Obstetricians and Gynecologists, the only ACOG level A is to get an ultrasound if you feel there's, a pelvic mass. And certainly many times you see a simple cyst or some very small septations, less than 10 centimeters. And this can be watched potentially, or management symptoms if the patient's symptomatic. Most clinicians that I know will do some tumor markers, such as OVA1, to reassure themselves that the ultrasound's correct. Now, if you have a clearly malignant ultrasound showing nodularity or fixed masses or ascites or evidence of abdominal disease, really should just get a baseline CA-125 and refer to GYN oncology. We're always happy to see those patients. An indeterminate ultrasound, as I said, we think that a large number of these are indeterminate. They will benefit from a formal risk assessment, in my opinion. Tumor markers are ACOG level B, and if you have a tumor marker that has an elevated risk of malignancy, suggest it to refer or get a consult to have someone on standby. I've done this a lot in my career at my institutions. And then if you have a low risk of malignancy, the general OBGYN certainly treats and doesn't need any further imaging if you're taking the patient to surgery. So we want to test it as a high negative predictive value so that you're not found that you don't have a false negative and you find that you have a cancer when you go into the operating room. Next slide. And this is an independent paper from Dr. Euland out of Kentucky, looking at the sensitivities of the Overa, OVA1, that Dr. Sea will talk about how we combine these. But if you're looking at the sensitivity for early stage ovarian cancer, there it's 89%, and OVA1 is 98% with clinical assessment. And again, higher in premenopausal and postmenopausal women. Comparing that to ROMA, the risk of ovarian malignancy algorithm, you see that it drops off into the 70s for sensitivity, and CA125 is actually worse than that. In early stage, 66%, premenopausal patients, 36%. Now, one of the issues was the specificity, and Dr. C is going to show us how by combining the two tests, OVA1 and Overa, into OVA1 Plus, we have increased the sensitivity into the 70% range. Excuse me. Next slide. So I would like to turn this over to Dr. Tamika Sea, who is a user of OVA1, and she can introduce herself. So Tamika, go ahead.
Thank you so much, Dr. Dunton. Hello, everyone. My name is Dr. Tamika Sea. I am a practicing OBGYN here in the Metro Atlanta area. I'm the owner and founder of Advanced Women's Care Center, which is a private practice here in Stockbridge, Georgia, roughly about 30 minutes outside of Metro Atlanta. I've been in practice for over 10 years, did my clinical training in Houston at the Methodist Hospital, where I completed my training, and have been in private practice since then in the Atlanta area. And I am here today to discuss the clinical application of OVA1 Plus in your office. Next slide, please. So of course, for any patient that we're going to be performing any surgical intervention for any reason, whether it be fibroids, primary ovarian masses, pelvic masses, what have you, in the preoperative course, we're going to perform a transvaginal ultrasound for those patients, to make sure that there's nothing we've missed prior to getting to the operating room. But then also, too, if there is an incidental ovarian lesion that's noted or a known ovarian lesion noted, we want to make sure that there's no evidence of any clinical suspicion for malignancy for the patient prior to going to the operating room. So, of course, ACOG, American College of OBGYN, has published a multitude of guidelines regarding the use of serum biomarkers in conjunction with clinical characteristics that are noted via ultrasound to give a patient a comprehensive risk assessment as to whether or not there's any potential risk factor for there being ovarian malignancy prior to going to the operating room. The multivariate index assays, OVA1 and Overa, are FDA-approved test clinical tools that we can perform that are indicated to assess for the clinical risk for malignancy in patients that are planned for surgery. And that's what we want to definitely stress, that this is a clinical tool that you want to utilize on your patients that you've already marked for surgical intervention, but you want to do additional screening and want to get additional information and have a better differential about an ovarian lesion that's present. And with OVA1 Plus, it combines the traditional OVA1 screening that we know well and with reflex Overa to decrease those false positive rates. As Dr. Dunton said, utilizing OVA1 Plus decreases those false positive rates and actually helps with the sensitivity and specificity in diagnosing those patients that are in premenopausal state, where it's much more difficult to discern whether or not there's an ovarian malignancy in those patients. Also, too, it's very important in those patients that have a clinically non-diagnostic CA125. Next slide, please. So as we discussed, OVA1 Plus is a reflex process that combines OVA1 with Overa. So OVA1 is our traditional 5 serum biomarker screening that we know well, and Overa, which is our second generation multivariate index assay, adding some additional biomarkers to the mix in order to decrease that risk factor for false positive rates and to also increase that sensitivity and specificity, especially in those premenopausal patients, as well as those patients that fall into the intermediate risk, which is roughly about 30% of the patients that you're going to perform this test for. So let's say you have Ms. Smith, she's coming in, she's here for her preoperative counseling for her surgery. She gets her transvaginal ultrasound performed, and we see that ovarian lesion that we did or didn't know about. That happens quite a bit in practice. Sometimes you find those masses incidentally, looking for something different. But let's say Ms. Smith comes in, she wants to, we are planning surgery for her for this ovarian mass, and we want to perform OVA1 in order to determine whether or not there's any clinical significance for malignancy. And we're going to go a little bit more in depth as to how the laboratory data report is going to show the scoring systems. But in general, the patient is going to be stratified into three scoring systems, either the low risk, intermediate risk, and markedly elevated risk. In the bottom left-hand corner, you can see the reference ranges for premenopausal patients. Low risk is going to be a relative risk score less than 5. Intermediate is going to be anywhere between 5 and 7, and the elevated risk is going to be above 7. For your postmenopausal patients, low risk is going to be less than 4.4. Intermediate is going to be anywhere between 4.4 and 6. And your elevated risk is going to be above 6. So your laboratory data result is going to show either a low risk, intermediate risk, or a markedly elevated risk. For those patients that have a low risk assessment, you're going to see your results reported in an over 1. And this is very clinically significant for your patients. As a clinician, it makes me feel more comfortable taking that patient to the operating room, knowing that the likelihood of this being a benign lesion is much more likely. And also gives your patient peace of mind as well. But let's say Ms. Smith comes back and she has an intermediate risk. And this is when over 1 plus comes into play, because then the over 1 will reflex to Overa, giving us additional biomarker screening that will be performed to determine whether or not the patient truly has an increased risk or a suspicion for malignancy. And your report is going to be, it's going to have an Overa scoring at the top. And then once again, if that Overa scoring comes back in a low risk category, feel very comfortable taking the patient as a generalist to the operating room to perform that surgical procedure. If it's in the elevated risk with an Overa scoring, definitely feel free to contact your GYN oncology colleagues and triage that patient for different surgical management per them. Of course, if the over 1 screening comes back markedly elevated, there is no indication to perform the Overa reflex. You will get an over 1 score, and of course, definitely send those patients over to your GYN oncology colleagues. Of course, down here at the bottom right, you're going to see over 1 and Overa plus, over 1 plus, and how all of those different testing systems have excellent sensitivity, but it's the specificity that we want to stress about over 1 plus, especially in that 30% of the population that's going to have that intermediate risk, and you don't know which way to triage that patient, whether or not to keep them in your office or to send them to your GYN oncologist. Next slide, please. So like we suggested, this is a testing strategy that you want to utilize for patients that are planned for surgery. Of course, we made clear that over 1 plus increases that specificity, decreases the false positive rates. It allows for that surgical management to be performed by the general gynecologist versus the GYN oncologist getting unnecessary consultations. And this is just so important. This is important, like I said, for the clinician, because the clinician can feel comfortable taking the patient to the operating room. You're not increasing the patient's morbidity by performing additional surgical procedures that may be needed down the line if you do actually encounter cancer at the time of surgery. And this allows for the patient it's a patient satisfier as well. Want to make sure that the patient feels comfortable with the information that you give them. Patients don't like going to see additional doctors if not necessary. I know for myself in my practice here in my institution, we don't have a GYN oncologist on staff, and the closest GYN oncologist that is on staff in my hospital system is roughly 45 minutes away. So this is another, once again, patient satisfier. If you get this testing performed, you feel very confident that the patient is being triaged to the appropriate person. Also, too, over 1 can increase the detection of risk for malignancy when CA-125 is non-diagnostic or even normal. Next slide, please. So, as we stated, over 1 is far superior to CA-125 by itself, especially in the situation where there's early stage ovarian malignancies that are present, where CA-125 actually may not be diagnostic informative, may actually be normal. So with, as Dr. Dunton discussed, those patients that are in that premenopausal range, where it's very difficult to determine whether or not there's an ovarian malignancy present, and also in those patients that have that intermediate risk or that indeterminate ultrasound, over 1 plus Overa are all going to supersede the usage of CA-125 by itself, especially in situations where the CA-125 is non-informative. Next slide, please. So this is very important clinical information in regards to the usage of CA-125 in your African American female population. So as we know, ovarian cancer in the African American female population, even though they as an ethnic group have a decreased incidence of ovarian cancer, they actually have a much higher and disproportionately affected rate of high grade and aggressive ovarian lesions. They usually are diagnosed at higher stages. They usually have lower survival rates as well as higher rates of recurrence. And of course, this statistical anomaly that's seen in the African American population, there's a number of confounders that affect this, right? So we know access is a part of this, possible aspects of socioeconomic status. Of course, African American women may have increased risk factors for comorbid conditions that increase their risk factors for ovarian cancer in general. But what we have found in clinical data is that the CA-125 is actually less sensitive in African American women in general. It actually is less expressed in African American women. So what that does is decreases our capability of finding early stage ovarian cancer in this patient population. So as you can see here in the table, if you look up at the top, you have CA-125 in the Caucasian ethnic group with the ACOG cutoff. You see roughly about a 74.4% sensitivity in CA-125 detecting a malignancy. But if you scroll down here to the bottom and you see that same CA-125 in African American patients with the same cutoff, only 33.3% of those patients are actually going to be identified with the usage of CA-125 alone. And that's a vast difference. That's a huge ethnic disparity with the usage of CA-125 by itself in its clinical application in African American patient population. So as you can see right above, the MIA, which is the Multivariate Index Assay, which is Overa, OVA1, OVA1 plus in the African American population, you see here 79.2% increased sensitivity. So this is excellent. This is a test that you definitely want to utilize in that patient population because, as you can see here, CA-125, which we are programmed to think about when we think about ovarian masses, risk for ovarian cancer, this is actually not a sensitive clinical indicator for African American women, and using a multivariate index assay like OVA1 plus Overa is going to be more beneficial for that patient population. Next slide. Now here is an actual laboratory report here showing you the OVA1 plus. So when you get your report, you'll see up at the top, these are all of the patient demographics here. The patient's menopausal status is also going to be present up at the top. And it's going to also let you know whether or not the ultrasound findings or any other clinical information regarding the patient will be up there at the top. And as you can see here, here is that Overa scoring that we discussed. This patient actually fell into the intermediate risk. As you can see here in her OVA1 scoring, her OVA1 scoring was 5. It reflects to Overa because she was in that intermediate category. When we got Overa, she actually had an elevated risk that was above 5. Now this is a patient that you likely are going to send to your GYN oncology colleagues to determine whether or not this patient truly has a susceptibility or increased risk factor for ovarian malignancy. You also see here reported the risk of malignancy in a low risk ultrasound category, a high risk ultrasound category, which is truly important, and we'll get into that a little bit more on the next slide. But that's information that you definitely want your patients to be aware of, and that's the information that they're going to want to hear from you. Doc, what is my relative risk? What is my percentage of this being an actual ovarian malignancy? And then also too, you see the CA-125 and the HE4, 2 serum biomarkers that are a part of the OVA1 screening. And actually in this patient, we're normal. So this shows you, this is a clinical scenario where OVA1 plus is superior to the usage of just that CA-125 or even the HE4 individually. Once you compile all of the risks, compile all of the ultrasound findings together to get that relative risk scoring, this is what allows for you to be able to triage your patients into the proper hands surgically. Next slide. And once again, we're talking about that risk of malignancy, and that is what your patients are going to want to hear. They're going to want to hear, if I have this mass, Dr. C, what is the likelihood of this actually being cancer? So in those patients that have that low risk ultrasound at the time of that preoperative transvaginal ultrasound. You know, that it was a simple cyst. We didn't see any thickened walls. We didn't see anything else concerning, relatively small, fluid filled, low risk ultrasound, no characteristics that suggest that there's a possible malignancy. That patient with that Ovarian scoring of 6.7 will have a 20.8% risk factor of this actually being a malignancy. And for me in my practice, that's still going to be a patient that I'm going to send to a GYN oncologist, triage them to a GYN oncologist to determine whether or not surgical intervention needs to be performed by them. And then, of course, if the patient has a high-risk ultrasound, and I think we're going to get into a little bit of what high-risk ultrasounds entail. Of course, if you see an ovarian mass, there's ascites, there's thickened walls, multiple septations, you see vascularity, you notice complex cystic and solid components. These are all going to be those clinical indicators or characteristics that would be determined as a high-risk ultrasound. That patient now has a 49.5% risk of that actually being a malignancy with that ovarian screening. That's definitely a patient that you want to refer out of your generalist OBGYN office and have them be seen by your GYN oncology colleagues to get the proper care and surgical intervention performed. Next. And that is the end of my portion of the discussion. I am happy to have Dr. Reilly discuss the clinical development and validation of OvaWatch. Dr. Reilly?
Great. Thank you very much, Dr. Sea. That was a great presentation. So first of all, I'd like to thank everyone for joining us here tonight. It's impressive that people are taking time out of the end of their day to do what we do, right? We learn what's the best way to take care of our patients, what are new options that are out there. I have the pleasure of presenting a new test that Aspira has developed over the last 3 or 4 years called OvaWatch. I'm currently the Director of Clinical Research and Innovation for Axia Women's Health across Ohio, Indiana, Kentucky, Pennsylvania, and New Jersey. I was a full-time OB-GYN for 30 years and stopped doing deliveries last year to take on this position. I still have an active minimally invasive gynecology practice and still see patients 3 days a week and then spend 2 to 2.5 days a week on my various research projects. Personally, for me, I've gotten involved in research after years in practice because I wanted to see what I could do to help the future of women and the future of how we take care of our own patients. I have 5 daughters of my own. We all have our own families. We care deeply about our patients and our families. Anything that we can do to further and improve the way that we take care of our patients moving forward, especially in the area of female oncology problems and especially ovarian cancer, then we're going to make a difference in their lifetime and in other women's life expectancies as well. First slide. So the question is for that patient who doesn't want to have surgery, for the patient who just started law school, for someone who just moved to a new city, has other personal or professional reasons why they would rather not have surgery, even though we found a mass on their exam in the office. They're relatively asymptomatic. There's the chime in the background here. So we're halfway through the presentation tonight. Sorry about that. So, but for that patient who wants to know, do I really have to have surgery right now? Is it safe to watch? How comfortable and confident can we be that the patient is safe waiting to have her surgery or perhaps not having the surgery at all? I know throughout the whole pandemic with COVID, ironically, it was when I was doing the study for Aspira for the OvaWatch project, and there were a lot of patients who didn't want to have surgery. So it was great to be able to be in the team that was developing and processing this test, seeing the different results, comparing it to the ultrasound, seeing the results from the surgery, and then realizing that this probably is a great option for patients and for physicians who want to wait or delay their surgery. So this is considered a 3rd generation multivariant index assay that assesses the actual malignancy risk and the safety of watching a patient with a pelvic mass. Next slide. So really this is an expansion of the whole suite, the OVA suite that Aspira has developed, and they've really dedicated their entire company to doing a better job of helping us to diagnose and work up pelvic masses prior to surgery or without surgery to get the best care of our patient that we possibly can. So it's a larger group of women who have a mass that you'd rather watch, probably 2 to 3 times of a percent of women would rather watch a mass unless they really have to have surgery or they don't have any symptoms, and it gives the physician the confidence to watch it as well. Next slide. So this was the paper that we submitted and was recently published on the validation of the deep neural network. So what's important to know about OvaWatch is this isn't just taking 7 serum markers and combining them. This analytical validation was done to put different weights on the different tests, including the patient's menopausal status and their age, and weigh that to make the negative predictive value as high as it possibly could be. So the majority of masses that we find, especially in patients who are under 55, are going to be benign, and even patients over 55, less than 20%, are going to turn out to be malignant. So the important thing is to look at this group of tests that are available, both through the OVA1 to OVA1 plus algorithm, and then for someone who wants to watch, to do the OvaWatch. So in this validation, we took 3,000 samples, and 50 of them were patients that we knew had ovarian cancer. It was from a serum bank, and used all of that data, all those samples, to validate the ability to detect patients who did have a cancer, but more importantly, have a very high negative predictive value of the patients who did not, and factored in the age of the patient and the menopausal status. Next slide. So this is the algorithm with how we did the validation, looking at 3,000 patients, and did an initial set looking at validation of how the different tests should be weighed, and then took that total sample of 2,000 with knowing that 5% of them did in fact have ovarian cancer, which is the 98 in this slide. Blinded the sample both for the lab workers and for the people looking at the histology from the surgery, and were able to validate and calculate the performance and calculate the metrics to come up with the highest negative predictive value that we could possibly have, to give you that extra sense of confidence for that patient who wants to wait to have their surgery. Next slide. So this is the most important statistic I think that you can express with your patients, is if we're looking at the bottom of this slide, the bottom right corner is that negative predictive value. So if you're going to watch a mass, you want to be very sure that in fact it is a benign mass. And if you look at the line with the premenopausal patients, over 99.5% negative predictive value, and that's looking at those 3,000 samples, and has subsequently now been validated in the clinical trial that we just completed. Looking at all comers, it's still 99.4%, and even in the postmenopausal patient, it's still over 99%. But in that premenopausal patient with that concerning appearing mass that doesn't want to have surgery, over 99.5% negative predictive value, which is something that you can rest peacefully at home knowing that, okay, not doing that patient surgery is the right thing for them to do, and not worry that there's a hidden malignancy that you're not aware of. Next slide. So this again looks at the OvaWatch report, and it's scored on the same scale as the OVA1, so there isn't confusion about the 0 to 10 scale, and it will still rate them as low probability or high probability of malignancy, which basically, based on this test, lets you know, are you comfortable watching it? And it still includes the serum markers, CA125 and HE4, so if you're used to following those and comfortable following those are still going to be listed. But again, based on ACOG and any other recommendation, those are really tumor markers for following the progression or hopefully the regression of patients with a known ovarian cancer and how they're responding to their surgery and to their treatments. But it's this multivariant index assay that gives you a true score that can give you that confidence to decide how to manage a given patient. Next slide. This zooms in again about it being the low probability and a negative predictive value of over 99%. And that does change a little bit based on the age of the patient, but you'll still see a extremely high negative predictive value and should have a high confidence of watching a patient if they do not want to proceed with surgery at this time. Next slide. So this, I think, is an interesting slide, and I think for most of us that are in the office and a patient presents and her symptoms aren't real specific, and you're thinking, oh, there probably isn't a whole lot going on, and she's already looked on the internet and she's concerned that she's got a cyst or she got endometriosis, or could I have ovarian cancer? So she comes to the office and you're listening to her history and aren't overly concerned, but do the exam and don't see a whole lot on the exam, but she's still concerned about her history. So you decide to go ahead and do a workup and do the ultrasound and some blood work. And then the patient talks to her friends and she goes on Google again and becomes even more anxious about her symptoms. And then she, lo and behold, has her ultrasound and they do see a 6 centimeter cyst, maybe with a septum, a little bit concerning, but not overly concerning, but also not a normal basic cyst. And patient's trying to decide whether she wants to have surgery or not. And fortunately, OvaWatch is an option. And the patient says, really, I don't feel that bad, and I'd rather not have surgery at this time in my life. And the OvaWatch comes back with a low risk of malignancy, again, confirming that negative predictive value of over 99%. Patient would rather not have surgery. The doctor themselves feel comfortable watching, knowing that the risk of this being a malignancy is extremely low. And this slide says 4 years later. We probably wouldn't wait 4 years to do follow-up. So, probably had yearly or every 6-month ultrasounds based on their symptoms and the appearance of the mass, just to look for progression versus worrying about seeing more concerning malignant signs on the ultrasound. But over the course of 3 to 4 years, her pain starts to increase. Ultrasound shows that the mass is larger, but still doesn't look overly malignant. At this point, the over 1+ is ordered because the mass is bigger and you decided to take her to surgery. Over 1+ confirms that it's still very low malignant potential. So then the gynecologist is able to do the surgery themselves, which I think we would all agree patients are much more comfortable having us for their surgery and going to their local hospital. I'm sure Charlie, Dr. Dunton does a great job, but he doesn't want to be spending his time and filling his office with benign cases when there's patients who truly have ovarian cancers who need his time and need his surgical skills. So to be able to confidently keep that patient within your practice, now it comes into a time in her life where she is comfortable having the surgery. It's gotten bigger, so she's a bit more symptomatic, and the patient goes in for surgery, and sure enough, it comes out as a benign ovarian cyst. But the patient was confident and comfortable with waiting. You were not stressed about watching something that was a bigger problem, didn't burden the medical system by doing a surgery too early or referring on to a gynecologist, and left with a happy patient who didn't have to leave your practice. Next slide. So this slide, when they presented it to me, I was like, well, these are the two easiest cases, correct? So if this was on your oral boards or this was a patient that you were reading their ultrasound, clearly on the left side of this slide is a benign cyst. Even if it has a daughter cell, there's very thin septums. There aren't any significant extra growths or shadows within the cyst itself, versus on the right, you've got papillary structures, you've got little ascites, there's some very solid components and very worrisome. But more importantly is those patients that are somewhere in between. And if you look at ACOG guidelines of referring someone if the cyst is greater than 10 centimeters, just yesterday I had someone come in with a very large cyst. It was 9.7, so under 10 centimeters, but it had internal echoes. She had gone to the emergency room for pain. and she was told it was most likely an ovarian cancer to see me, but that she probably need to see an oncologist. And the mass, she had a CAT scan, so we did an ultrasound, and it was, again, in between these two extremes on the slide. It was large, it did have a lot of shadows, it did have some internal echoes. My opinion looked more like a dermoid versus a ovarian cancer, but the patient had already been told by the emergency room doctor that it probably was an ovarian cancer. On this hand, she was symptomatic, so she wants to have surgery. I went ahead and ordered the OVA1, which reflects to the overa, came back as low risk for malignancy, and she's going to stay within our practice, and her surgery is scheduled for next week. The week before, I had a 70-year-old who got a CAT scan for hip pain, and she has a 7-centimeter relatively clear cyst, but in someone that age, a 7-centimeter cyst certainly gets your attention. She had no other symptoms. She got the ultrasound because of her hip pain. So I was able to order OVA watch for her, which isn't publicly released yet, but through a special program, we're doing some of the early submissions through my practice. And her OVA watch came back as normal, low risk for malignancy. She has no other symptoms. She really doesn't want to do anything before the holidays. So we'll probably revisit with her after the holidays and see if in fact she wants to have that cyst out before the risk for torsion or other problems. But the reality of it is she can feel comfortable and confident not having her surgery heading into the holidays, and perhaps not even having the surgery after the holidays. So she was very happy with how her test results came back, and I was fortunate enough that I'm allowed to use the test right now because we were on the development team, but it should be approved, it sounds like, by the end of the year. Next slide. So back to Ryan here for some closing comments, and then we'll be all available, the entire panel, for any questions you might have.
Thank you, Dr. Reilly. Really, really exciting to learn from you and Dr. Sea and Dr. Dunton that walk us through the journey of patient with ovarian cancer risk. And we're so proud to share with you that Aspira product contribute to this process for your care of your patient. Next slide, please. So to put in the perspective what Dr. Sea and Dr. Reilly mentioned about how the patient been managed, particularly for ovarian cancer. So here, this slide show you the number of the statistics in the US annually. So if you look at on the all the way on the right side, we have about 1.2 to 1.5 million women yearly diagnosis with adnexal masses, relatively a big number. And among those patients considered to be surgery, between 300 to 400,000 patients a year. So these patients, as Dr. C and Dr. Reilly mentioned early on, that selected either by their choices or their clinician determination to undergo surgery. And they turn out to be the total ovarian cancer yearly diagnosed in the United States is roughly about 20,000. So Aspira team is really proudly to provide this product that supporting this journey in which that our goal is to provide early assessment for the patient with an adnexal mass for their cancer risk. And additionally, because of our tool, we provide additional data point for the clinician to determine how to care for their patient. Next slide, please. So what you hear today is a two product that we spanning the entire journey for the patient who initially diagnosed with an adnexal mass. If the patient was initially diagnosed as indeterminate or non-malignant, depend on the clinician determination whether the size of the tumor, the ultrasound risk, or the patient history, family history. So we have a product called Overwatch to be launched very soon, provide that supporting tool for the clinician to make the clinical management decision, whether to wait and watch for the patient or refer the patient to appropriate specialist or even consider for surgery. More importantly, if the patient was scheduled for or planned for surgery, we have a product called OVA1 Plus, in which a combination of, like Dr. Sea mentioned early on, two important FDA clear products, Over-1 and Ovarian, where in which the patient will be assessed whether the low risk or elevated risk and refer to appropriate medical oncologist or the general gynecologist to monitor and manage the surgical plan for this patient. So as you hear today from our clinician panel, that we are the only one and available will provide this entire product for the patient from early detection to manage clinical care for the patient, including surgical management. Next slide, please. So with that, I'm so happy to conclude the webinar today and open the floor for questions. And we have all the physicians, three physicians here, Dr. Dunton, Dr. Reilly, and Dr. Sea, ready to answer any question you might have.
I see that there's a question that's come into the chat. Yana, the question is, how is Overwatch different from Over-1 Plus? So I believe best people to address that would likely be either Dr. Phan, Dr. Dunton, Dr. Reilly.
Yeah, I'm happy to walk through, elaborate what Dr. Reilly mentioned early on with our technology. So Over-1 and Ovarian are two FDA clear products that intended use for patient schedule for patient for surgery. Overwatch is the new product that even though we use the protein marker very similarly, we have a broader panel of surgery, biomarker that for patients not planned for surgery. And this algorithm developed based on the biomarker together with the age of the patient and the menopause status, intended use for the patient who initially assessed by clinician as indeterminate or benign or non-malignant. So these patients tend to be in a low risk category, have not been planned for surgery, and this Overwatch where coming from. So I will leave for Dr. Dunton and Dr. Reilly elaborate on it for their clinical assessment for how to use this Overwatch.
So it utilizes 7 biomarkers, age and menopausal status, into a different algorithm that is optimized for negative predictive value. And that's why we can get such high negative predictive values that we get good, but not that good, and that is reassuring. So that's the way it is different. The Over-1 algorithm is different from the Ovarian algorithm, and the Overwatch algorithm is also different. They've been optimized for different populations and different reasons. Sorry, you want to add anything, or you're muted, I think.
Yeah, Yanni muted me. I didn't have the power to unmute myself. So again, this came up in several presentations that we've done previously, and that's why I tried to emphasize when we were looking at that integrated neural network is it's not just taking the 7 biomarkers and looking at them at their face value and adding in age and menopause. They're weighted differently to maximize the negative predictive value versus in Over-1 Plus, those algorithms are truly analyzed and weighted to weigh malignant potential. And it sounds like the same thing, but it's really two different things. And you're not just looking at a CA-125 and looking at that value and how old the patient is and saying, oh, I can probably do this surgery, oh, it probably is a cancer. These are weighted specifically to aid in your decision making. And certainly many of the oncologists, I've talked with the oncologists here in Cincinnati about how they make their decision. They all have their list of the serum biomarkers that they feel like have been more reliable in their experience. But unless you're following all of your patients, you're following their outcomes, you're following the actual quantitative measurements of those serum markers, it's really not a sound decision making. And that's the difference with these panels, looking at thousands and thousands of patients, some of which we know did have ovarian cancer, many of them who had had surgery and the pathology was analyzed. They were able to validate over and over again both the negative predictive value and the sensitivity and specificity for the patients who did move forward to having surgery and get the pathology. So I think it's a subtle difference that is hard to see on the surface, but it's the weighting of the different values that drives that negative predictive value way up over 99.5%.
And Dr. Phan, I see a question for you in the chat regarding the OvaWatch release. Can you speak to the release timeline for OvaWatch?
Yes, we are planning to release OvaWatch very soon in Q4 2022, and I would say that everyone, all the clinicians that Dr. Reilly mentioned, I talk across the country, really exciting to wait for us to ready to launch it OvaWatch. Right now, the OvaWatch, logistically, operationally, the company is ready to launch. We're waiting for a few more items that in the lab, also in the supply process to ready for a patient, and we will announce the launching of OvaWatch very, very soon.
Okay. I have a question for Dr. Sea. Any case examples of using OVA1 in practice that you may have?
Yes, actually, I had a patient this week where we actually utilized OVA1 plus. She was a long-time patient of mine. Previous hysterectomy, had one ovary that was still present. Actually, showed up to the emergency room with evidence of acute appendicitis, and had a CT scan that was performed that suggested that there was a 4-centimeter adnexal mass, along with evidence of acute appendicitis. At that time, the patient actually did go to surgery for her appendix. General surgery took her back for the acute appendicitis, had the surgery performed. She's doing well after that. And then she came to me for additional screening and management of the ovarian lesion that was noted via CT scan. We performed the ultrasound. As Dr. Reilly suggested, there were some clinical characteristics of the ultrasound that were a little suspicious. We saw some areas of vascularity. We noted multiple septations, but overall it was a small lesion, 4 centimeters. But I went ahead and performed the OVA1 to determine whether or not there was any relative risk for a potential malignancy. And lo and behold, actual OVA1 plus is what showed up on my desk because there was a reflex to Overa because the patient fell into an intermediate risk. Like we suggested, about 30% of patients will do so. And the Overa scoring was actually above normal, so she was in an elevated risk. And I actually sent her this week to our GYN oncologist in Atlanta at our sister hospital. So she will be getting her surgical management by a GYN oncologist versus myself. And that was the right thing for her. After getting this testing performed, it made it a clear and easy decision for us to triage her to a GYN oncologist, and I felt comfortable with that decision.
Okay. Let's see. Okay. I don't see any more questions popping up. If there are any questions, feel free to email them. We will relay them to the doctors, but I will move into closing remarks.
Jenna, before you do that, just so you know that if you are new at ordering OVA products and you have clinical questions, both myself and Dr. Leo Twiggs are available for peer-to-peer consultations, and you can talk to your representative or call into the company, and we can schedule a time to talk about a specific patient.
Yes, and there is the number and email as well to do that, to learn more or order the test kits. Okay.
Really great. Thank you so much, Dr. Dunton, Dr. Reilly, and Dr. Sea, and thank you for everyone that attend the webinar tonight. Hopefully that you're gonna learn something from Dr. Sea and Dr. Reilly, who actually utilize the Aspira product and for their patient care. And we have the number here. The phone number is 844-277-4721. And we also have that available on the website of Aspira, womanhealth.com. Looking forward to hear from everyone. Thank you again.
Great.
Thank you.
Thank you.